So I want to welcome and thank all of you for coming out tonight. My name is Christine Bongiorno, and I'm the Director of Health and Human Services here in Arlington. And our department, along with the police department, have sponsored tonight's event. We've invited all of the guests. And I have here with me up front, I'm going to start with Chief Ryan. This is Arlington Police Chief Frederick Ryan. We have Dr. Naomi Levitt here from the Cambridge Court. She's the senior psychologist from the clinic. We have Mike Duggan, who is the owner of a local company called Wicked Sober, and he's a resource. He will be a resource for you to help connect people, whether you're a clinician or a family member, to resources in the area. And then we have Mary Wheeler from Health Innovations, who will be the main speaker for tonight's program, which is why most of you signed up for tonight. As you are aware, we have seen a spike in heroin use in the state of Massachusetts and here in Arlington as well. And many of you are aware that we've had 4 fatalities as a result of heroin overdoses here in Arlington since last October. That is alarming. What we see is that the cases have hit people in their 20s and 30s, and that's scary, and we want to be able to provide resources to all of you to prevent that. Every week we receive reports of more overdoses. Our fire department and our police departments are out there trying to save people that have experienced an overdose. Many of you have loved ones that are either using heroin. Some of you are clinicians. I see some clinicians in the audience, and we want to be able to provide you with the resources necessary to prevent overdoses and deaths. So we hope to partner with you, all of you, to rid our community of heroin use and overdoses. And at this time, I'm going to turn it over to Chief Ryan, who will give a little welcome.
Well, thank you. Again, my name is Fred Ryan. I serve as the Chief of Police in Arlington. I want to thank Christine and all of our staff at the Department of Health and Human Services for partnering with the police department in trying to tackle this issue proactively and to be in the prevention, treatment, and support role rather than the enforcement role. Obviously, the police department does have an enforcement responsibility when it comes to unlawful controlled substances, and we take that responsibility very seriously. But we also recognize that that is a very, very, very small piece of the pie when it comes to prevention of heroin overdoses and heroin deaths. On the enforcement end, just for informational purposes, you all should know that we do have 2 police officers assigned to regional drug task forces. One is assigned to a Middlesex County Drug Task Force. The other is assigned to a United States Department of Justice Drug Enforcement Agency task force. And they look at drug distribution trends on a regional basis. So for example, our officer that's teamed up with the federal officers, they're looking at some of this fentanyl-laced heroin that's coming in from northern New Jersey and New York by train into Boston, then some locales in Somerville, and on into Arlington. So we're trying to, address it as far away as northern New Jersey to prevent it from getting here into Arlington. So those efforts are ongoing. We recognize that their value, the value of stopping that is important, but in the overall picture, when you look at it from 30,000 feet, it's a very small piece of the pie. Secondly, I wanted to point out that, for your loved ones and family members who are suffering from addiction, contacting the police during non-business hours is a reasonable approach when you're wrestling with a crisis and you don't know what to do with a family member or a loved one. We are connected to the service providers, and our first priority in dealing with somebody suffering from substance addiction is to get them help. I mean, yes, we have an enforcement role, but our primary function is saving lives and enhancing the quality of life in the community. We recognize in many ways that our sort of drug policy in America over the past several decades will probably, as we're sitting in our rocking chairs in our senior years looking back, a lot of errors were made along the way. So we in Arlington feel that we're a little bit ahead of the curve in terms of, yes, we recognize our enforcement role, but we place a very high priority on prevention and treatment. We had some officers that were fortunate enough to go to Health Innovations presentation, and they came back and communicated with Christine and her staff and raved about the presentation. So I'm not going to waste any more of your time because I understand it's a fabulous presentation. I want to thank you for coming. Yeah, and I think the doctor's going to say a few words. Thank you.
So I think as you heard, I work in the Cambridge Court Clinic in the courthouse in Cambridge, and if people can't hear me, let me know. I tend to speak softly. And I want to tell you about a mechanism that can help you intervene if you're having difficulty with a loved one who suffers from substance abuse or alcohol abuse. I don't know if anybody here has heard of what we call Section 35s. Anybody? Okay. So we call it Section 35s. Other people say you're being sectioned. Basically, it's a provision of Massachusetts law whereby an individual can be involuntarily committed for treatment. So the person does not have to have committed a crime or be even accused of a crime, but they can, in theory, be committed for treatment up to 90 days. It's Massachusetts General Laws, Chapter 123, Section 35. That's why we call it Section 35s. So what I want to do is just give you a quick overview of what the law is and then just tell you a little bit about the nuts and bolts. I've left my card over there, so if anybody has any questions, feel free to give me a call. And there are a couple of other handouts there also that I'll explain as we go on. So Section 35 has basically 3 criteria for commitment. The person has to be either a substance abuser or an alcohol abuser, and the statute defines what those are. Inhalants also are included. They have to present a likelihood of serious harm either to themselves or to someone else, and that has to be by reason of their substance abuse. So if you have somebody who gets into fights a lot, but it has nothing to do with their alcohol use, for example, that would not meet the criteria for commitment. I should say that different courts handle things differently. Arlington obviously goes to the Cambridge District Court. It's also important to note that if you do decide to come in and file for a Section 35, the person needs to be located in, say, Arlington or someplace that the Cambridge Court covers. So how does the whole process work? Someone comes into the courthouse, files a petition saying that another individual is a substance abuser, and presents a likelihood of harm. So there are 6 categories of people who can do that, and I'm going to see if I can remember them. A spouse, a blood relative, police officer, guardian, officer of the court, and spouse, police officer, blood relative, physician, yeah. Thank you. Are you a physician?
Sorry?
Are you a physician?
No, I'm an addiction specialist.
Okay, so it's a physician, not a clinician, just to be clear. So that person would come into the court, you'd be directed to the court clinic, you will speak with a clinician, we'll have you fill out a form, and I'm going to put these forms over there so that you have an idea of the kinds of information that we're going to ask you. But basically the information that we need is some evidence that the person is using or drinking, and any data that you have that would go to the likelihood of harm. So we'll ask you if the person has had recent overdoses, recent hospitalizations, if they get into fights because of either using or trying to procure substances. If somebody has a medical condition that's exacerbated by the substance use, that would constitute likelihood of harm. If somebody's falling asleep with lit cigarettes in the house, that's something that would count. In my book, if anybody is driving while under the influence, that's plenty for me to recommend commitment. So we do a brief interview asking you this kind of information, and then we present that to the judge and make a recommendation about whether we think that it makes sense for the person to be brought into court. You know, I can tell you 99 times out of 100, at the point that a family member comes to court, it is a very serious situation, and the judges almost always order the person into court. I won't go into the technicality, but it's also important for you to know that what happens is the police will be summoned, they'll come to the house or wherever the person will be located, and you all can correct me if I'm wrong, they're put into handcuffs, put into the squad car, and brought to the courthouse. Yes? Once they reach the courthouse, they're put into a holding cell. So with anybody else who's been arrested for a crime, which is, you know, unfortunate because they haven't committed a crime, they're assigned an attorney. The attorney will talk with them and then will be called in to conduct an evaluation. So part of our evaluation is exactly what you've told us. And to the extent that you have specific information, you saw the person, you know, with needles, you saw needles in the room, and if you want to take a picture of that, that's all of those things are helpful. Sometimes people have brought in photographs of a loved one, you know, 3 months ago, and now they've lost 40 pounds or something. That kind of information is helpful. So the person is assigned an attorney, we do an evaluation, then we make a recommendation to the judge about whether we think the person meets commitment criteria, so is using and presents a likelihood of serious harm. That's a high bar. You know, essentially the court is committing somebody for up to 90 days without them having committed any crime. So the court takes it very seriously. If the person is committed, ideally they will go to one of two facilities operated by the Department of Public Health. One is called the Women's Addiction Treatment Center, and the other is the Men's Addiction Treatment Center. I like to say they're relatively new, but I think at this point they've been in operation for 6 or 7, 8 years. They're very good facilities. I've left handouts. The pink and the blue handouts describe those facilities. I do want to make sure that people understand those are the DPH handouts. They're not Department of Mental Health handouts. So ideally, they are committed to one of these two facilities for treatment. So in other words, they don't have to, the person does not have to be under the influence at the point that they come to the courthouse or at the point that they're committed. You just need to have a recent history and be fairly confident that the person is continuing to use substances. If there are no beds in these two facilities, men will go to what people know as the Addiction Center in Bridgewater, which is a Department of Correction facility. It is dedicated mostly to treatment of substance abusers, but it's run by the Department of Correction. It looks like a Department of Correction facility. You know, there are correction officers. It's a different, very different kind of setting. They do get treatment. Women, on the other hand, are sent to MCI Framingham, and at MCI Framingham they get no treatment. They get medically detoxed. They can go to, you know, AA, you know, community groups that come in at night. But because of the way the sort of vendor situation is, they virtually get no treatment. Ideally, they're on the list to be admitted to WATC when there's a bed. Practically speaking, that kind of never happens because there's always this, you know, these are the facilities for the entire state. The commitment is for a period not to exceed 90 days. The people can be discharged much sooner than that. I think I'm sure the average length of stay last year in both of those facilities was under 25 days. Both of those facilities step people down, and they work very hard to set up aftercare. The other thing that, sure.
Is Bridgewater also a place they send them, and do they get treatment there?
Yes, so Bridgewater's the facility I was talking about before. If there are no beds at the DPH facility, they're sent to Bridgewater, the addiction center. It's now called MASSAC, and they do get treatment. It's a much larger facility. They get, like, you know, it's more classes, but they do get treatment. And they, you know, they have individual counselors, and to some extent they work for discharge planning.
Do they get medication to help them off it?
Yeah,
They do
yeah.
cold turkey.
Yeah, no, they do. And women can get methadone treatment at WATC. I think they don't do that at MCI Framingham unless the woman's pregnant. The other thing that people should be aware of is that If you've filed a petition for commitment and for some reason the judge does not order commitment and the situation changes, gets worse, you get additional information, you can come in the next day and file again. There's nothing to stop you from doing that. I guess I could say plenty more, but my time is up. Again, I left my card there. If anybody has any questions, I really encourage you to call. I'm happy to talk about it and to help out to the extent that we can. Thanks.
How's everyone doing tonight? My name is Michael Duggan. I started a company called Wicked Sober out of Massachusetts. We're an outreach program. Just want to give you a little information, kind of what it is that we're trying to do, a little background information on myself. I'm in recovery. I actually got addicted into prescription pills in high school. I got an injury in hockey. Went to go hit the person on the other team and broke my wrist, and I had extensive nerve damage. Pins in my arm, and the solution to the pain the doctor gave me at that time was prescription pain medication. And growing up, you hear the word heroin. A lot of times, I'm sure there's a lot of families in this room that hear heroin and it terrifies you, has that name branding effect. But when you're a kid growing up and you hear, Percocet or, they call them blues or 30s, it doesn't really have that name branding effect. You have a lot of kids that are taking these prescription pills not realizing what it is that they're taking, synthetic heroin. And, that just, was the case with me as well. And, I went to school right down the street from Arlington, went to Bentley College. I played D2 football there. And my studies, I was one of those kids always did well in high school as far as classes were concerned. And when I went to college, I started gravitating towards my friends from back home who weren't going to school. And, I just felt more comfortable. That's who I gravitated towards. And, with the prescription pills, it ended up, getting into a habit, ended up opening up the door and leading me into heroin eventually. And, I speak, about this just in the, hopes of just, exposing the stigma of addiction. A lot of the times is, somebody that's, homeless or somebody that, comes from a very poor family. But the fact of the matter is there's really no face to addiction. There's many faces to it. Rich, poor, young, old, it doesn't matter who you are, where you come from. You have a lot of kids, nowadays, especially in this generation, that were exposed to OxyContin when I was growing up, that they're no longer manufacturing, and now they're about to release a Zohydro, which is another pill that unfortunately is going to have a lot of threat just because it's not tamper resistant. So again, you're able to abuse it. There's no abuse deterrent to it. You can sniff it, you can inject it, and it certainly doesn't have that name branding effect that heroin has. A young kid, growing up, here's Zohydro. It doesn't terrify you, but unfortunately, again, it just brings it back to a synthetic opioid. When with me in particular, fortunately, my mother worked with my school at Bentley, and I was able to take a medical leave of absence and go to a detox and an inpatient program and eventually a sober living home. And, through steps of working on myself and counseling and treatment, I was able to work on defects of behavior, defects of character, and, my behaviors in general. And I was able to, start, getting myself and getting my life back in order and going back to Bentley and finishing and getting my degree. And eventually, after a few years, me and my father basically, worked to start Wicked Sober. I just remember going through the process of trying to get myself a bed in detox and how alone I felt in that process. A lot of times when you're calling and you're an addict and you're trying to get help, you hear, no, sorry, we can't help you. Call back tomorrow. And unfortunately, when you're going through it, your solution that day is to use and get high. And most kids, they don't call back the next day. And unfortunately, this goes on for weeks, and a lot of times they just give up in the process, and they get into trouble, or they're selling as a way of maintaining their habit, and they end up overdosing. And I've lost a few friends from Arlington, from overdose deaths, and it really is unfortunate. So we offer a lot of support services with individuals. We make phone calls with them and try to help them navigate through the treatment process. There's a lot of red tape walls that come up, throughout the process. If you go to a privately funded detox like, St. Elizabeth's or McLean's, unfortunately, and you're trying to get into a halfway house, it's a very difficult process because they won't take you in a holding from a private detox. If you get out of a private detox, a lot of residential programs will no longer take you as a self-referral. So it just becomes a nightmare to navigate. A lot of it, what we do is we work with a lot of family organizations in Massachusetts, like Learn to Cope, And we try to educate parents on support groups that they can get involved with so they can meet other families who are going through it and get information on overdose prevention methods such as Narcan. We work with parents as far as putting together a plan of treatment and then intervene on the situation and try to help get their son or daughter or loved one to agree to go into a program. A lot of the success we've been having has primarily been the fact that when we're dealing with somebody who's going through it, they can relate to us because we've also been through it ourselves. They can identify with us, and sometimes you're able to break through the walls of communication. I just remember with me when my mother would try to speak to me about what it is that she was concerned about. As soon as she started talking to me, I would take more of a defensive approach, and the walls would go up, and I would resort back to basically isolating and surrounding myself with just people who are using like me. So we try to get involved. If anybody has any questions or any information they're looking for, the website's very easy to remember. It's wickedsober.com. We have brochures and pamphlets that are in the back as well. But feel free to ask anything that we can get involved with in the community. We definitely, right now, being in Arlington, being from Arlington, this is definitely my home base. This is where it really, hits home for me. I'm really passionate about the community here. It's one of those communities that a lot of people, everybody knows everybody. So it's not somebody else's problem. The fact of the matter is, I know many families that have and struggle with somebody that they know is going through it at this time, whether it's a brother, sister, loved one, cousin. Anybody can really relate to this problem and this epidemic that we're going through. So I just want to thank everybody for their time, and any questions, you can see me after the meeting as well. Thank you.
My name is Mary. I work for Healthy Streets Outreach Program. We're a program of health innovations. Our home base is out of Lynn. We serve primarily Essex County. Been doing Narcan training since about 2003, and it's been legal in Massachusetts since 2005. Lynn got our Narcan pilot site in 2007, which is great. So we've been doing it for a while. This is Amy.
No.
Amy Delaney Monks works for the Boston Needle Exchange Program, which is on Albany Street in Boston, right across from Boston Medical Center. So if you ever need services out there, she's your girl. How many people have ever had a Narcan training or an overdose prevention training before? 1, 2, 3, a few folks. Okay. This is really hard for me. It is, yeah. Okay. So a little bit about the Narcan pilot in terms of legality and what it means to carry the medication. Once you're enrolled in the pilot, which we'll do at the end, and it's an anonymous enrollment, I don't need your name, your address, nothing like that. You're legally able to carry the nasal Narcan and administer it to someone else, right? I left a sheet on the table about the Good Samaritan law, which passed a few years ago, and it's just an addition to the regular Good Samaritan law, but it has two different pieces. One piece is if I'm overdosed and Amy calls 911 for me, or if she's out, which overdosed, and I call 911 for her, there is less risk that we're going to get arrested. It's not a free-for-all, though, right? If somebody has a warrant, if someone they'll get arrested. If someone has Section 8 housing or they have a child, they can lose those things on the scene of an overdose. What we will be protected from is a charge called knowingly being present, where drugs are kept. So if we're on the scene of an overdose, that's why we've called 911. That charge, you shouldn't be charged with it anymore. And simple possession. So dirty drug paraphernalia, empty baggies, things like that, folks shouldn't be charged for on the scene of an overdose. You're not protected against possession with intent to distribute, trafficking charges, weapons, anything in plain view that's illegal, right? It's helped in the last few years to encourage folks to call 911. So working in Lynn for almost a decade, we have a lot of overdoses in Lynn, a lot of non-fatals. So our non-fatals are up, but our fatals are down dramatically, way down, which is great, which means people are calling. They're calling within an appropriate amount of time. They're not afraid of the police showing up. They're not afraid to have first responders come because they know they have a little bit of protection. And people have had this training a lot of times, right? So the way the pilot is set up is it's sponsored by Department of Public Health. We have a medical director. His name is Dr. Alex Wally, and he works out of Boston Medical Center, and essentially he wrote a standing order So weirdos like me and Amy can go out into the street and distribute Narcan and do overdose prevention training, which is wonderful. Doctors can prescribe Narcan now. If I was a physician, I could prescribe you Narcan knowing that you're going to use it on someone else. That's the second piece to the Good Samaritan law, which is great. Walgreens in Massachusetts is going to start carrying Narcan. Pharmacists will be able to train individuals. They will have to pay. Narcan, an injectable, is about $12. A nasal kit is about $40 to $50, depending. So we have this standing order. It allows us to distribute the medication. Then there's a bunch of approved sites, approved trainers, and then you all will be approved responders, right? If anybody has any questions at any point, just throw your hand up. Don't wait till the end. I don't want you to forget. All right.
Question. So you have somebody who's suffering from an overdose, and a family member administers Narcan, takes them out of the overdose. Now do we have a patient who's immediately experiencing withdrawals and is in need of medical attention beyond just the Narcan?
Oh God, yeah. So we touch on that later, but in case are you going to stay the whole time? Because if you're not, I'll answer it now.
Yes, I'll be here.
Not to put you on the spot, Chief.
Well, I know the answer, but I don't want people thinking, that we're going to be administering this stuff, and then, okay, John Doe's fine.
No.
They're
no.
still in need of medical attention.
So the drug Narcan is a temporary solution to a problem that can last many, many, many hours, especially if it's a methadone overdose. If someone's bought methadone in the street, they take the methadone, they overdose. That overdose can last up to 20 hours. So if Amy does a lot of methadone, she stops breathing, I Narcan her, she wakes up. 20 to 90 minutes later, when the Narcan wears off, she's back out again. So she needs to be put in a hospital for at least 24 hours, right? The Narcan is not a silver bullet. I know that there's been so much press about this miracle wonder drug. It doesn't work every time. You have to administer the medication in a reasonable amount of time. Not everybody makes it. Once I Narcan someone and they wake up, they can go back into their overdose when the medication wears off. The rule of thumb for us is kind of once someone turns blue, even if they kind of come up, if I said, hey, Amy, and she kind of woke up a little bit, she still needs medical attention, because once you've turned blue, there is something wrong, right? That person needs to get on the phone with 911, make sure that she gets to the hospital, right? I want to explain what Narcan does, just in case anybody's not familiar. So it's called naloxone hydrochloride is the actual name of the medication. We call it Narcan. That's the name you hear a lot in the newspapers or in general. It's an opioid antagonist, which means it's the opposite. So we have opioid receptors in our brain. Opioids would be your heroin, fentanyl, Dilaudid, hydrocodones, oxycodones, which you might know, Perks, Vikes, those are all the brand names. Now the Zohydra will be coming out. They all go to a specific spot in our brain. If I do too much of that opiate, the first thing that stops is my breathing, right? The second thing to stop is my brain function, and the last thing to stop is my heartbeat, which is the only upside of an opiate overdose, is that I can have a heartbeat for a while, which will help me sustain some life, right? It's not like a cocaine overdose where my heart stops, and there's not too much you can do at that point, right? The Narcan literally goes into my brain, right, through my bloodstream, whether it's injected into fatty tissue, injected into a vein or a nasal spray. You never inject Narcan in someone's chest, despite movies. Nasal spray hits my bloodstream, goes into my brain, kicks the opiate off my receptors and covers them. So all that drug is still in there, right? But it can't get back onto the opiate receptors. 20 to 90 minutes after this medication wakes me up, it's going to start to dissolve, right? So all the drug comes back onto my receptors, which means I can be high again or I can overdose again, right? In that time, this is basically just enough to kind of get somebody up, walking, talking, breathing, to get them the medical intervention that they need, right? Get them to the emergency room. How many people in the room have seen an overdose? It's okay. Okay, a few folks. All right, it's a really scary experience, right? It might be a little bit different if you are a first responder or if you're a medical professional. You may have seen it a lot more. You might be used to it. You're more used to responding. Maybe you can stay calm. For lay people, it can be really, really scary. How many people think that they would panic? Not one panicker. I don't believe it. All right. That's okay. That's why we have 911, right? So, starting to overdose, I've done my drug, right? Obviously, if I am an injection drug user, it's going to hit me quickly. If I sniff drugs, there's a little bit of a lag time before it gets into my bloodstream, and the same thing with pills. It doesn't mean that you can't overdose on those things, right? Sometimes there's this misconception that, oh, I just do pills, oh, I just sniff dope, I'm not going to OD. But that's not the case, right? That can happen. We see a lot of polydrug overdoses, and I'm sure the police can attest to this. Benzos, heroin, benzos, alcohol, and heroin, all different combinations of drugs. So a benzo, which is important for folks to know, is an antipsychotic, anti-anxiety drug. They're really cheap and really easy to get. And in conjunction with an opiate, it makes you really high, right? So people will use it if they have a high tolerance, right? If they're just maintaining with an opiate so they're not sick, they'll throw on a benzo so they feel the effect of the drug. Some people legitimately need those benzos but might use too many of them, right? This medication is not going to work on a benzo, but when in doubt, give it. If I'm with you, you go unconscious, I don't know what is wrong with you, I can Narcan you, nothing's going to happen to you if it's not an opiate overdose, right? It's not going to hurt anybody, which is the nice part. So if you have kids at home that don't get high, or you have other people at home around you that don't use drugs, and they come in contact with the Narcan and they decide for some reason to spray it up their nose, nothing is going to happen. It's not a dangerous medication. You can't get high on it, right? Amy is at risk for an overdose for a couple different reasons, right? Maybe she just walked out of detox. 5 to 7 days in a detox, or 3 days, 4 days, person's tolerance has shifted, right? They might pee dirty on a drug screen, but their tolerance has shifted. So now she's at risk for an overdose. Another misconception we see, people walking out of detox thinking they can do the same amount of drug they did when they walked in. Some might be able to, some can't, right? Puts you at risk for an overdose. Maybe she's just coming out of jail, right? She's been in 6 months, 9 months, 2 years, 10 years, whatever, doesn't matter. Today she's getting high. Maybe she has advanced hepatitis C or HIV, right? Those two things are going to make her body compromised. If she's not eating, sleeping, or drinking enough water, all of those things are going to contribute to her being at risk for an overdose, right? Mixing drugs, and a huge one, if she's overdosed before, she's more likely to overdose again, right? If Amy is an overdoser and she uses alone in a place where no one can find her, really good chance that she's going to suffer a fatal overdose. A lot of people have problems with a non-fatal overdose, which when we deal with folks that are using, a lot of them go right to the fatality. But when we start talking about what else can happen, right? I'll be like, have you ever gone out, woken yourself up 6 to 7 hours later? You don't know what happened. Well, yeah, of course. I'm like, okay, well, technically that's an overdose, right? Any nerve damage. So I had a kid, we do a detox group every Tuesday, one of the kids, I asked this question of the crew in the group. One kid said, yeah, I've had nerve damage for 5 years. I don't think it's going to get any better because I opened the fridge, I overdosed, and fell back on my leg, right? He was out for about 5 hours before he finally kind of came to on his own, but he has permanent nerve damage now. Sometimes people will end up, their lungs will start to fill up with water, they will wake up, but they'll come out with pneumonia, right? Or they'll come out with all different kinds of problems from a non-fatal overdose. They may have the beginnings of kidney failure. If Amy is overdosed 13 times, which is not unheard of, brain damage, right? She could have some brain damage. We do the Narcan enrollments, we're like, how many times have you overdosed? People be like, 6, 7, 13, 20 times. Jeez, loud. That means that her person has gone without enough oxygen to her brain 2, 3, 4, 5, however many times somebody has overdosed, right? Yes. So Chief Ryan mentioned the fentanyl, which is important, which has changed our message a little bit over the last few months. Pharmaceutical fentanyl is very expensive, so people have, of course, made an analog of fentanyl called acetylfentanyl, which you can make in a lab. It's not quite as potent as pharmaceutical grade fentanyl, but it is still about 40% more potent than heroin, right? So the problem with that is folks that are using the fentanyl, they overdose faster, right? So sometimes you have anywhere from 5 minutes, 10 minutes, up to an hour, 2 hours before somebody kind of goes out on you, right? It's not always an immediate thing. The fentanyl is putting people out really quickly, so there's less intervention time. It's also calling for more Narcan. So the pilot program, we give out 1 kit unless people tell us that they know they need more. So this is 1 Narcan kit. The cut in whatever is going around in some parts of the state is taking 3, 4 doses, sometimes more. So we have a lot of reports that people are giving 4 doses of this and it's not working, and EMS is showing up and they're having to give multiple doses of the injectable naloxone to actually wake the person up, right? People are dying within the first 10 minutes of their overdose. A gentleman just passed away in the BMC bathroom right next to the security desk, where it's a high traffic bathroom. A lot of people use drugs in there, so the fact that he died within that first 10 minutes is pretty serious. So we're talking a lot with people about rescue breathing, 911. You need to get that bus on the way, the ambulance on the way right away, right? That needs to happen, 911. Rescue breathing, which we'll kind of go over a little bit. So those messages, if anybody is talking with folks that are using or family members that have loved ones at home that are using, you have to stress that message. So even if you don't have the Narcan.
Are there any adverse consequences to too much Narcan?
Depends on who you ask. So you can't give someone too much Narcan in the sense that you're going to hurt them or kill them. They may want to hurt or kill you if they get too much Narcan. So stand back. So no, right? The problem with Narcan is, like we said, it takes the opiate off the receptor. So what happens is folks start to go into withdrawal. The different ways of giving the Narcan makes a difference on how quick the person responds and how sick they get, how quick, right? So if I inject it into a vein, number one, it's all going in and it's going in quick. If I inject it into a muscle, it's all going in, but it's going to take a little bit longer to hit me. The nasal spray comes on a little bit slower, and some drips out, which is the one downside to the nasal spray. The other downside to the nasal spray is if someone has sniffed drugs for a long time, pills or powders, they've shredded their mucous membranes, which is where the Narcan needs to absorb into, which is why when I show you how to use it, you'll understand why we do the half dose. So Narcan throws people into withdrawal. Saves their life, throws them into withdrawal. So people say, well, why do people get mad when you wake them up with Narcan? Well, the last thing somebody remembers is feeling good, right? The next thing they know is they're sick, everybody's yelling, they're surrounded by uniforms, flashlights, they don't know what happened, right? You're telling them one thing, they're saying, no, that didn't happen, right? So it's a whole big scene and it's scary. People get violent, people get scared. People that aren't having an overdose, that become conscious on a 911 call, sometimes get volatile too because they're scared and they don't know what's going on. So it's not just people on overdoses that get a little cranky when you wake them up. So upside, folks are alive. Downside of giving someone so much Narcan they hit withdrawal is that if you put me in withdrawal, I have more drugs somewhere on me, right? You didn't find them. Hospital didn't find them. I beat it out of the hospital, AMA, against medical advice. I do my drug. I'm not going to feel it until the Narcan wears off. And now I have twice as much in my system, right? So when my Narcan finally wears off, the drugs I overdosed on the first go round come back onto my brain along with what I just put into my body. So if you Narcan somebody and they do get sick, it's really important to remind them of that. They may or may not listen to you, but you have to remind them. I know you're sick, I know you don't feel good, but if you do more dope on top of it, you're gonna overdose again, you're gonna end up back in my hospital bed, or you might die.
One of our recent fatalities was that exact scenario. Narcan earlier in the evening, into the emergency room, released against medical advice, fatal later in the night.
And that's unfortunately happens more often than people would like to think. Sometimes, I mean, we used to get overdose reports when Revere Fire Department started carrying the Narcan. There were some folks that would get 911 called on them. There was a couple kids like 3 times in a day, 2 or 3 times, same thing. They'd go into the hospital, they'd leave AMA, use more drugs, go back into the overdose. Unfortunately, we can't control anyone's behavior but our own, but it is important to let people know, right, that's a reality, right? Sometimes they listen, sometimes they don't. The overdoses that we've seen or we reversed, when the person starts to kind of come out of it, we try and say, you overdosed, you overdosed, you overdosed, kind of like reinforce the message, you know, because maybe they'll agree with you, maybe they won't. Maybe they were just dizzy, tired, all kinds of any other excuse folks have. So, Amy's at risk for an OD, right? If Amy was really, really, really dark skinned, right? If she starts to turn blue or gray, I might not be able to tell because of the color of her skin. If that's the case, flip the lip down, right? It'll start turning blue or gray, or the fingernail beds, right? So an overdose, like I said, the breathing stops first, right? Amy does her drug. Does it always look like this? Nod in an overdose? Not necessarily, right? She might be up, running a mouth, walking, talking around, blah, 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 and then all of a sudden she'll just kind of 1,000-yard stare, boom, she's out. That's problematic because if she smashes her face, now we have blood, right? She might go do her drug, nod out, go into an overdose. Sometimes people tense up badly. It almost mirrors a seizure. They tense up really bad, including their jaw clenches shut, which can make it really hard to give them rescue breaths, right? If that's the case with the jaw clenched, we don't advise people to try and undo the jaw because you can get your fingers bit off. You can try and do the jaw.
Oh, yeah, got that.
Try and do the, hold it in my mouth. Jaw lock, our jaws are a hinge. Worst case scenario, we've had people breathe up someone's nose, right? Or you can try and breathe through their teeth. I mean, it's do or die. You might be sitting here like, oh, I'd never do that, but you say that, you know, here, but if it's someone you really care about, you're gonna do what you gotta do. So she starts to overdose. She looks a little funny, right? I might hear her gasping for air. Close. Good, right? Agonal breathing, right? Breathing once every couple seconds. She's turning blue, clammy, right? I might hear the death gurgle. It's like a snore almost in the back of the throat. We've had folks pass away because maybe they relapsed or were using and someone in the house didn't know, and they heard that sound, and because it sounded so much like a snore, they thought nothing was wrong, and they woke up the next day and the person had passed away. So we always say there's nothing wrong with giving somebody a quick elbow. If you're not sure, maybe you think they were using, maybe not. If she's just sleeping, she'll go back to sleep. But if she's overdosing, I can make sure she doesn't die, right? So she might be doing all of these things. My first step, hey, are you okay, right? If she's just in a deep nod, she's gonna respond to me, right? If she doesn't respond to me verbally and I give her a quick shake and nothing happens, my next step is a sternum rub, right? I take my knuckles, I rub them on her breastbone. If I can't get to this bone for some reason, right, or I just can't get a good enough dig in there, I can do it right under her nose. It hurts a lot, right? 10 to 15 seconds. right? If she's just really high, she's gonna kind of come out and be like, tell me to leave her alone. If she's blue, though, I really need to get her medical attention, all right? So I give her the sternum rub, 10 to 15 seconds. There's no response. Nothing's happening. I know she's out. My next step is 911. Remember, cell phones go to state police first. Don't say, I'm at 359 Washington Street. See you when you get here, right? Well, which one? If you're in a city where there's 5 different Washington streets, right? Be mindful. I mean, it's hard to think in the moment of crisis, but, you know, I'm in Arlington. I'm at 25 Broadway, 2nd floor. Somebody here is not breathing. Somebody here is unconscious. I can't get them up. I'll see you when you get here. Everybody's a little bit different, right? Some people want to put 911 on speaker and keep in touch, right? Some people have to hang up. If it's just me and her, chances are I'm probably going to hang up once I've given the address, right?
In Arlington, the call will be transferred to Arlington,
Yep.
and our call takers are trained in emergency medical dispatch. So they're going to ask the caller to stay on the line, and they're going to walk you through those steps that you just described.
Are they
Our
trained?
call triggers are trained.
Are they trained on how to use the nasal Narcan by any chance? So if I called the Arlington 911 and said, I have this Narcan, but I don't know how to use it, or I can't remember how to use it.
Yeah, it's a state emergency medical dispatch certification. I don't know the answer whether it's, I can find that out specific, if there are specific instructions to Narcan. But all the steps that you just described, the 911 dispatcher will tell you or instruct you to do over the phone. So you'll be asked to stay on the line.
Oh, yeah, the chest compression, so we'll get to that. They also want to know a little bit more about what's going on, right? That's why speakerphone is a great option, because then if I have to do stuff to her, if I have to give her the Narcan or have to do the breathing, I can respond, I can hear the instructions, but I can still do what I got to do for her, right? 911 with somebody who's not breathing, this is where we are, right? What happens if you are in a car, right? You got to say that. We're in a car, we're in a parking lot. We deal with a lot of folks who use drugs. A lot of them don't stay on the scene of the overdose. This is what it is, right? So we talk to folks a lot about if you have to make that call and you're going to leave, you need to make sure that the first responders know exactly where that person is, right? So I've given her the sternum rub. I've called 911. My next step is to try and do rescue breathing for her. That is super important, especially if you don't have Narcan. Even if you do have Narcan, it's important, but if you don't, especially. So rescue breathing is you try and get someone as flat as you possibly can, which it looks really easy here, but in real time, it's not easy. Really? Dead. So, as flat as you can get them. Sometimes it's not going to be this perfect, right? You might have to do a little bit of a slouch, move around best you can. If it's in a car, throw the seat back, right? So 2 fingers under their chin and a hand on their forehead, and you tilt the head back, right? You want to open their airway best you can. Pinch the nose and open their mouth if you can. If you have blood, vomit, mucus, any of those things on their nose, on their mouth, it's your call, right? What are you going to do in the moment? A lot of people will just wipe it away, right? Put the person on their side first, wipe it away, get it out of the way, and do their thing. Some people don't want to do that, which is understandable. If I'm really nervous, we used to give out breathing masks in the Narcan kit, the plastic shield that covered the person, and it was a barrier, but they were really expensive and nobody was using them. People were just kind of going for it, right? So we don't give them out. Worst case scenario, if you have a piece of shirt you can put between you and the person, it's not 100%, but it's not skin to skin, right? We're gonna do that. So I open her mouth as best I can, right? I'm gonna seal my mouth around hers. When I'm doing the breathing, I can see her chest rising, right? So I'm gonna breathe in twice. Easy, and then back off, right? 1, 2, 3, 4, 5. Do it again. If her chest isn't rising, there's a couple things I know. My seal isn't right. I need to try it again. Maybe her airway is still blocked, so I can try and reposition her head. She might have something in her mouth. If you're not a first responder, don't go digging around in there because you might do more damage, right? In that case, if your rescue breathing is not working. So we continue with the 1 breath, we count to 5. 1 breath, count to 5. We do that 2 or 3 times. We grab our kit. We open it up. If you can't see it, don't worry about it. We have a bunch. You can mess around with them. So we pop off these 2 yellow caps. This is what makes it a nasal spray. This goes flying out of your hand, rolls onto the table. You can search for it if you want to, but you can try and give the Narcan like this. The problem with this is that more dribbles out. So you really want to have this guy. This twists on the end, right? This is the hardest part when you're in the midst of an overdose, right? If you're shaking, it's really hard to get this on, so we'll show you a little trick. If you take the kit, the purple cap comes off of this vial, which is glass. Don't pop it off with your teeth, right? You need to be gentle. When you put it in, you twist about 1.5 times. Everything is threaded, so it fits together. If I'm really nervous and I start pushing, I'm gonna spray my dose out, right? So there needs to be some level of calm, right, while you're doing this. If I shove this in and I break the glass vial, now what am I gonna do? So, twist. You cannot keep your Narcan like this, right? Some people do, they go back to use it, it's evaporated because the seal has been broken. You cannot leave it like this. 1.5 twists, I'm going to stick it, I'm not gonna do it. Stick it up her nostril, right? I'm gonna spray half up one side. I'm gonna go up the other side, spray the other half, right? Until this is empty, right? You can see the lines. It's 2 cc's in Narcan. Do the best you can, right? Half and half. Back to breathing. So I'm breathing, counting to 5. Breathing, counting to 5. Right? Do that 2 to 3 minutes. If she's not waking up, her color will start to come back, her eyes might start to flutter. If nothing is happening, I give her my 2nd dose. All right? By that time, 911 should have arrived. If for some reason they haven't gotten there and taken over for you, keep breathing. Do not stop, right? That person really needs your oxygen. Keep it going, right? 911 shows up, get out of the way, let them do their job, even if you're freaking out. Move. You make their job harder if you're, hysterical and in their way. So back off. They'll take care of it from there. Now, awesome job. If she starts to wake up before 911 arrives, this can be problematic because now she is an adult who can refuse care. In our experiences waking people up, we've had the local Lynn PD say, well, since you're outside on the sidewalk, you can either come with us for public intoxication or go to the ER, pick one. And we're like, see you in the ER, pal. Which is really helpful for us because now we know that person is obviously going to choose going to the ER over being arrested, and now they're getting medical attention and now they're going, even though they were awake already when 911 arrived, right? If somebody refuses medical attention, you may have the PD step in for you, right, which is helpful. If she refuses and bolts before EMS or 911 arrives, you got to let her know before she goes that the Narcan's going to wear off. That is not ideal, right? Most of the time, EMS shows up pretty quick. How do you feel?
I'm good. It was nasal.
Okay. So now they're awake. They go to the ER. They take over from there. So a couple of things about, we call it overdose postvention. Overdoses are really traumatic for folks. They can be really, really scary. We deal with a lot of families, a lot of learn to cope parents who have reversed their kids' overdoses, who end up not being able to sleep, not being able to eat. A lot of them stay up all night watching their kids sleep for 24 hours, watching their chest go up and down. That's a trauma response, right? That is anxiety, that is post-traumatic stress. If you have any of those symptoms after you witness an overdose, you can call us, you can go to Learn to Cope, seek private counseling. Sometimes people chalk it up to, my kid is a substance user, so it's not really post-traumatic stress. It's not something I need therapy for or support for, which is not true. It's like any other trauma event, right? Just because someone's drug use is involved doesn't matter, right? Any questions?
You were that good.
None? Nothing? Concerns?
So 911.
Yes. So the nasal spray is, I'm not going to say it's all that's available. I forgot the recovery position, which I'm going to show you. The nasal spray is all that we are able to give out. The plastic device, you can screw a needle onto the end and give it intramuscular, which we don't give out, but it is an option for folks. If you ever came to see us and that was your method of choice, we would obviously show you how to do that. This is just a little bit safer and easier for everybody. So if somebody wakes up and they're angry, there's nobody's holding a needle when arms are flying and, you know, furniture's flying and whatever else is going on. So, but that's all we have.
One thing about the nasal administration as well is a lot of times people don't know that they've overdosed, so we have this idea.
You have to.
It's obnoxious.
It's hard. Get over it.
We have this idea that an overdose is as traumatic for the person who's suffering, and that's not real. A lot of times when we reverse an overdose, someone will not believe that they've overdosed. They will say, I was just dizzy, I just accidentally walked into a FedEx truck, stop picking my nose. We've heard any number of things from people, so I think it's important to understand that the nasal is a really gentle wake up, and when we get report backs, very few people admit to having any sort of withdrawal symptoms. When we talk about people being angry, it's usually because they've gotten additional Narcan administered IV or IM. That was it.
So I did forget the recovery position, which is important. Oh, question. We
Right, so the only two ways of injection is either through receiving this through either injection or through the nasal passage.
So IV in the vein,
Yeah.
intramuscular, and then a nasal spray.
And if someone had been using a heavy amount of drugs in the nasal cavity recently, is the nasal spray still going to work?
So obviously, if they don't have any mucous membrane left, which hopefully they have some to absorb the medication, it's going to have a harder time working, right? Which is where the 911 and breathing comes in, very important. It's also if they have a deviated septum, which sometimes folks know about you, sometimes they don't. So that's why we say half and half, right? Because let's say one side is really, really damaged, but the other one is okay, at least they're getting half that dose up the good side. We have met a few people over the years who have switched from sniffing to injection, and they don't have anything, they don't have anything left. So their only option is to get the Narcan kit and use it as an injectable. So yeah, it's definitely a concern. And also if someone's nose is broken and there's a lot of blood, mucus, vomit pouring out of their nose, that's going to be problematic too, because it's covering up those mucous membranes. So it's going to be hard for the
What about
absorption.
switching? If you shoot it up the nose, it's going to eventually turn up in the back of the throat. Is there any, will that mucous membrane absorb any of that Narcan?
So no, which is weird because that's like with Suboxone, when you put it under your tongue,
Yeah.
the Narcan doesn't dissolve, like doesn't hit your bloodstream under the tongue. It's only hits your bloodstream if you inject it. So a lot of time, I've had some parents ask us, if I put this in my kid's dinner, is he gonna, I'm like, no, I'm sorry. Probably not gonna work like that. You shouldn't do that anyway. It's a bad plan for all involved. But hitting the back of the throat, you would think, it's a good question we should ask Dr. Wally. But as far as I know, not gonna happen.
Right. It's not pink enough.
Pink parts.
Pink parts.
So let's say I don't want to do the rescue breathing because I'm scared or there's blood or anything going on. I'm going to put the person with me in this position. This is the recovery position. I apologize for the quality of the photocopies. We're a low-budget show here, no color copies. This way, if she takes a seizure or anything starts to happen, her leg keeps her from moving around too much. Her mouth is facing down, so if I don't want to do rescue breathing on her, I can't sit her up I don't want to lay her on her back. I definitely don't want to lay her on her stomach. This way I can also help anything in her mouth come out, and I can still administer the Narcan to her, right? So this is the position that we want you to put somebody in. If she starts to wake up, kind of come to, right, but she's still real out of it, I can put her in this position as well, right? So she doesn't hurt herself, or in case she starts to vomit when she wakes up, which could happen, can come out of her mouth safely so she doesn't choke. Right. Any other questions? Is there any?
How does the public get can the public that has a loved one living with them that they suspect, they're like claim they're off it, but you see them nodding sometimes and you wonder.
So we brought kits tonight, so we can sign you up and you can go home with an Narcan kit tonight.
That's a nasal, right?
Yes, it's the nasal. Otherwise, folks can go to, so we're in Arlington, so the closest place would be probably the Cambridge Needle Exchange Program or the Boston Needle Exchange Program, which a lot of folks aren't necessarily comfortable going to, and that's okay. You can always call one of the pilots. Some of the pilot programs will do home visits, whether you're using or you're a family member, it doesn't matter to us. Some of us will go to houses.
Learn to cope too, you can go there with other parents.
So Learn to Cope is another one. It's a family group. One of the things that they've kind of asked us to talk about is, since they're the first parent group in the entire nation who's able to give out Narcan, so they're really wonderful. They have run into some issues with people just showing up to the meeting for Narcan only, which we've talked to the woman that runs it, and that's a little bit disruptive to some of them. So I would try and call the pilot first, right, to see if one of us will come out and meet you.
If you're here in Arlington, Right Turn is our clinic in Arlington Center. I'm the CEO and you can give us a call and we will provide you with Narcan.
Also, worst case scenario, your doctor can prescribe it. You just have to make sure your local pharmacy will fill the prescription. It is covered by insurance, which is amazing, right?
And you said Walgreens will be carrying it.
So yes, so very recently, so Rhode Island has been doing this for a while, where they don't have pilot sites like ours. But what you can do is walk into the pharmacy and the pharmacist will give you a training and give you the medication. Unfortunately, it's cash only, or, which is too bad because it's expensive. So the Walgreens in Massachusetts, call first. Are you guys stocking Narcan? So I have the list in my office of a bunch of places that are now stocking it. You should be able to walk in.
So we've got 2 Walgreens right here in Mass Ave.
It might be worth it to go in and check it out. I mean, we'll give you a kit tonight, but go in, check it out. Hey, do you guys carry Narcan? If you do not now, when are you going to? We'll call you back when that happens, right? So the medication is getting out there. Local community health centers are starting to prescribe it more readily. It's really, moving in Massachusetts. We're really ahead of the curve on this one, which is, sort of. So our focus for the pilot sites is obviously folks that are using drugs. So there's been several thousand overdose reversals reported back to the pilot sites, the majority of which were drug user to drug user. Obviously, they're usually the ones on the scene, which is great. So those are the pilot sites. Our number one target is folks that are actually using the drugs. The second would be significant others, users or non-users that have someone in the house that are living with them that are using, families, spouses, partners. And then legislation in Massachusetts has just starting to make its way to the top for all first responders to be able to carry it if they so choose without having to go through the pilot sites, which is nice for them because they can set up their own policies and procedures.
Is there a expiration on the Narcan kit?
About 1.5 years. So the kits we have are good for about 1.5 years. I think the dates on the ones I have are September 2015. It's a room temperature medication, right? I recommend for those of you that carry a bag, carry it in your bag. Try not to leave it in a vehicle when it gets really cold. Obviously, if you go to try to use Narcan and it's frozen, it's no good to you. You don't want to let it get super, super hot.
Keep out of the reach of children, please.
Of course, keep out of reach of children. If they did get a hold of it and they did spray it up their nose, it's not going to hurt them, which is the upside. The one concern, though, is that vial is glass, right? So if a little one did get their hands on it and it broke, then you got a big problem on your hands, right?
It's an interesting piece, and they'll want to see what it is, and then you'll be out of Narcan.
Yeah. They'll spray your Narcan out.
They'll
Yeah.
say, "Mommy, Daddy, look what I made."
Not unheard of.
So if I put a kit in my police car, it'll freeze?
If it's winter, yes, it can freeze. So that's, one of the downsides about New England is if we keep it in our cars, it can freeze in the winter. Some of the other departments, the police departments that we've worked with prior, they had a lot of discussion about that because they were like, well, what are we going to do? Does every officer keep it in our bag and we bring it in and out every single day? Because, chances are you're not going to have a heated garage for, all your first responders. So it is something to think about down the line if Arlington chooses to get on board, or the freezing and the overheating can be problematic.
Do those temperature switches take away the quality of the Narcan? Still work?
That's a good question.
Yeah.
So we always say on the scene of an overdose, if your Narcan got really hot in your car in August, you're going to use it anyway, right? The problem comes if it's frozen. After the expiration date, we obviously can't say, oh yeah, it's going to work 100%. You can go ahead and give it because it's not going to hurt, but after it expires. So in terms of getting refills, so if you are worried about the temperature range, or it does expire, or you use it on someone, you lose it, it gets confiscated or given away, go back to one of the pilot sites or give one of them a call and they'll get you a new kit. It's free to get the new kit, especially if you use it to reverse an overdose. That's how we prove that this whole deal works, is by folks using the medication and reporting back to us if it gets broken.
So, but like you're saying that you maybe had an experience, you've had a fluctuation, and you've still seen it have results?
Yeah, so we see a lot of folks who are in the streets and they're sleeping outside all winter, all summer. They've had to use it and it has worked in some circumstances for them. It's just not ideal. I mean, it is.
Ideal, but there's still you don't. I'm not going to use it just because it got cold and now I can't put it in my car. Like
No. If you have it and you need it, use it.
And it doesn't become toxic if it's expired. It will still have some effectiveness if it's expired.
So we've asked our MD that, our doctor, and his answer is usually the thing that happens after expiration is it starts to slowly lose its potency, but not toxic, doesn't rot. It's not.
That's good.
Any other questions? Any other questions for Naomi? Any questions for Michael? Nothing? Quiet crew. So the way we're going to do it is we'll set up shop over there. It does take us a few minutes per person to go through the enrollment if you want the kit. You have to put the medication together so you can physically feel how it works. So just be patient with us and we'll try and get through it as fast as we can.
Great. I want to thank everyone for coming. I especially want to thank Health Innovations. Thank you, Mary and Amy, for coming out. I also want to recognize a few people in the audience that have been key to bringing this to Arlington, and others that also play a role in community prevention. We have Rebecca Wolf. She's the mental health clinician that works out of the police department. She's available to help families in need. We have Colleen Legere. She's the director of the Youth Counseling Center here in town, EYCC, available to help families with children. Support groups, whatnot. We also have Cindy Bouvier from the high school. We had Cindy Curran from the high school, a few people that can also help out as well. And we have Woody Giesman. He is from Right Turn, also here in Arlington. So thank you all for coming. Thank you, Mike Duggan, Naomi, Chief Ryan. Thank you. You're welcome. Thank you.